That's for no live, Chair.
Thank you very much. Morning, colleagues. We will make a start if that's okay. It's 9:32. Welcome to the Shropshire Health and Wellbeing Board. For those of you that don't know me, I'm Simon Whitehouse. I'm Chief Executive with NHS Shropshire, Telford and Wickham. Hopefully, colleagues can hear and see me at your teams as well. And for anybody watching online, hopefully as well, you can see and hear us that are in the room. So normal rules apply. Please, if people could raise their hands if they wish to speak during the meeting. There are microphones in front of you. You'll need to press the button so that the light comes on so that you can speak. It's fine in the room because we can hear you, but it also enables you to be heard by colleagues online. So that would be appreciated, please. And we've got agenda and papers that were published. So thank you, Louisa and team, for the work behind the scenes to get all the papers together. I'm going to go around the room and the virtual room and do introductions, if that's okay. Just ask people to do name, role, organisation. Before I do that, I'll just do the apologies that we've received. So we've received apologies from David Crosby, Chief Officer with Shropshire Partners in Care. We've received apologies from Simon Hardiman, Chief Fire Officer, but Guy here instead. Patricia Davis, Chief Exec with Shropshire Community Health, and Paula Mawson, Assistant Director of Integration Healthy Population, Shropshire Council. Have we had apologies from anybody else, or anybody else want to raise apologies that we've not already been notified of? Nope. Okay, good, thank you. So let's go around the room then and do introductions, and then we'll get through the first bit of the structure of the meeting and get into the main conversations. And apologies to colleagues sitting behind you, I've got my back to, but hopefully you can hear us okay. If there's any issues, tap me on the shoulder and it'll be fine, I'm sure. Okay, I'm going to go to my right. So, Rachel.
Hi, everyone. I'm Rachel Robinson, Director for Public Health. What I'm doing this morning.
Good morning. My name's Nigel Lee. I'm the Director of Strategy and Partnerships for South, and also Director of Strategy for the ICB. I'm now substantive rather than interim for the minutes, if that's okay. Oh, sorry, for South.
Yeah.
Good morning, Guy Williams. I'm the Assistant Chief Officer for Shropshire Fire and Rescue Service and representing Simon, who's our Chief today.
Morning, I'm Tanya Miles. I'm the Executive Director of People for Shropshire Council, and we need to leave the meeting at 11:30 today.
Good morning, I'm Louisa Jones. I'm a Business Support Lead for Partnerships. Thank you. Sorry, I pressed the wrong thing. No, it's that one.
Tim Ward, Committee Officer.
Liz Sweeney, Healthy Lives Team Manager.
Claire Parker, Director of Partnerships in Place for the ICB.
Penny Basin, Head of Joint Partnerships, Shropshire Telford and ICB and Shropshire Council.
Good morning, Stuart Bill, Superintendent, West Mercia Police.
Lynn Corley, Chief Officer, Health Watch Shropshire.
Good morning, I'm Councillor Cecilia Motley, Shropshire Councillor, portfolio holder for adult social care and public health.
I'm going to do colleagues online as well, if that's okay. So, Liam.
Hi, Liam Lawton, Head of Children, Young People and Family Services for MPFT.
Welcome, Jess.
Morning, everyone. Jess Edwards, Public Health Intelligence Manager, Shropshire Council.
Caroline.
Morning, everyone. Caroline Chioto, Mental Health Prevention and Suicide Prevention Lead, Public Health.
Welcome. Naomi. Literally just joined us. I came to you to do introductions, Naomi.
Trying to get off mute.
I'll come.
Sorry, are we doing introductions?
Oh, yes, sorry.
Yeah, sorry about that.
Your timing was perfect, mine was poor.
Okay, not at all. Hi, everyone. Naomi Roach, Personalised Care and Women's Health Hub Leads for Shropshire, Telford and Wrecon.
Laura.
Hi, everyone. Laura Fisher, Head of Housing Resettlement Independent Living at Shropshire Council.
and councillor. Personal, sorry.
Kirsty? Maybe she can hear.
Kirsty?
Oh, she's on mute.
No, okay, I'll come back. Somebody's going to need to help now because there's additional people that have added in the right who I missed. So is there a
Peggy Mullock.
It's just Peggy and Maria.
Maria Jones.
And Maria.
Yep.
I'm hoping that you can still hear us because actually we couldn't hear those interruptions, but I'll work on the principle that all is good. Okay, let's go through agenda proper if that's okay. So disposable pecuniary interests, reminder to all committee members and board members to declare on the register of interest anything that's not previously been declared and to make sure that's up to date and accurate, please. Minutes of the last meeting. They are in the pack, so hopefully people have had the opportunity of those. I'm going to require some help because I've sent my apologies to the last meeting, but I'm going to do for accuracy first, page 1, page 2, page 3, page 4, page 5, page 6, and page 7. I assume they are accurate records, so thank you. If somebody could propose those, please. Thank you, councillor. Somebody could second those, please. Thank you, Claire. Happy with those. Are there any actions on there that don't get picked up elsewhere on the agenda or picked up in other parts of the conversation? I couldn't see anything. Yes. Nope. Okay, I will move us on then if that's okay. Thank you for those and thank you for an accurate set of minutes. In terms of public question time, we have had one public question which I will read out in full, and then Rachel's got a response that she'll provide. So a public question is submitted by Mike Richardson, Shrewsbury Friends of the Earth. He would like to have it read to the committee. At the last meeting on November the 16th, we asked, when will the board demand decisive action with targeted dates on air quality problems? Although this question was asked of the board, the response which was read out was received from the Public Protection Officer, stating that work was developing rapidly on measures and an air quality action plan was to be expected in early 2024. The AQAP is itself well overdue. A report to the board in September 2021 confirmed the need to update the 2008 plan. We are now 5 months on and there is no AQAP, no report from the PPO and no demand from the board for progress. By the time of the next meeting in June, it will be 7 months. In addition, the board received a 2022-2023 public health report at the last meeting, which made one minor reference to air quality within living conditions with no further detail, which we need to remind you is one of the board's priorities. Once again, we would remind you that Shrewsbury and Bridgenorth have had illegal pollution within UK law since 2010. In that time, although UK limits have not been changed, the World Health Organization have drastically reduced their recommended limits in recognition of the harm caused. So we need to ask again that the board responds. When will you be taking this issue seriously, pushing for action and demanding deadlines? Rachel.
Thank you, and thank you for the question. I'll read the response, but we will publish the response in full on the website and obviously share that directly as well. So we appreciate the public's concern and interest in air quality in Shropshire. We are pleased to report that significant strides have been made in developing comprehensive air quality action plans for both Bridgenorth and Shrewsbury. These draft plans have now been submitted to DEFRA for feedback and demonstrate our commitment to improving air quality and public health. While the air quality action plans are statutory documents aimed at meeting current UK objective levels, Shropshire Council is seeking to ensure that proposed measures will generate reductions to both current objective levels and work towards further improvement beyond this, wherever feasible within constraints. Bridgenorth Air Quality Action Plan. The draft Bridgenorth Air Quality Action Plan outlines a series of measures aimed at reducing air pollution and improving the health and quality of life for residents and visitors. Key priorities include improving traffic flow, managing traffic within the air quality management action area through the use of variable messaging signs, and working with local schools to develop school travel plans. These initiatives are expected to significantly contribute to reductions of nitrogen dioxide levels, particularly from diesel vehicles, which have been identified as a prominent source of emissions within the air quality management area. The Shrewsbury Air Quality Action Plan includes a range of measures for both future ambitions and those already funded and progress through to development. A key measure in Shrewsbury is the Levelling Up Fund 2, the gyratory scheme, which is proposed to introduce new active travel corridors, cycleways, and redistribute the road network in the primary hotspot of the air quality management action area. These works have currently been modelled to significantly reduce concentrations within the area once the gyratory work is complete. The plan demonstrates sustainable transport, the promotion of electric vehicles, and the enhancement of cycling and walking infrastructure. These measures are not only aimed at meeting current legal requirements, but also at exceeding them across the wider town centre area to ensure health and wellbeing of our community. Consultation and next steps. Both air quality action plans are set to go up for public consultation within the next few weeks. We encourage public participation in the process, and as community input is invaluable to the success of these plans. The feedback received will be carefully considered and integrated into the final versions of the plans. We've already met with a number of local residents, councillors and business groups in our air quality action plans and recently received positive appraisal feedback from DEFRA on the content and the direction of both draft documents. We understand the urgency of this matter and assure you that Shropshire Council is taking action. The forthcoming consultations and the detailed measures within the plans are clear indications of our ongoing approach to addressing air quality concerns in Shropshire. The draft documents are currently being revised to take account of DEFRA's feedbacks. We hope to publish them for consultation in the coming weeks. As soon as firm timescales are clear, they will be advertised via our usual communication channels, including social media and our website. We will encourage the input from the Health and Wellbeing Board and all interested parties in this process. We look forward to your continued engagement and support as we work together to improve air quality in our region.
Thank you, Rachel. And as you said at the start, we published that report, so I think there was a lot in there. But thank you for that, and thank you for that update. Okay, I'm going to move us into, we've had no other public questions, so I'm going to move us into the agenda items proper. So item 5 on our agenda, the JSNA update, focus on children, young people, JSNA and youth survey. As ever, we've said the items we'll have at the start of the meeting will be the ones that we want the biggest discussion on. So looking forward to the introductions, take us through the headlines in terms of the paper, assume the paper's been read and understood, and then let's get into the conversation discussion around that. So Rachel, are you introducing this, or am I going straight to Jess and Rakiba?
Okay.
So Jess, am I coming to you first?
Yes, please. I'll just share my screen. 1 second. If you just let me know when you can see first slide.
Yeah, we can see it now. If you could go into slideshow, that would be even
Sure.
better.
Let me just try and do it so it doesn't throw my screens off. 1 second.
That's fab. Thank you very much.
Okay, brilliant. So just a quick change to the agenda. We were going to bring the youth survey with this JSNA pack today, but the youth survey hasn't been signed off yet. So it will be coming in June, hopefully, with Helena Williams' team. So today we're just looking at the children, young people JSNA. That's all right.
Absolutely.
Okay, fab. So good morning, everyone. I am the Public Health Intelligence Manager for Shropshire Council, and I've got Rakiba with me today, who's my senior analyst. And we are here to give you an overview of the progress of the CYP JSNA and present to the board a draft of the first 2 chapters, Population and Context and Early Years. Our aim is to provide an understanding of the needs of children and young people in Shropshire, to set the scene for programs of work relating to CYPs, which I see is on the agenda today for the board. And we're seeking feedback on any areas you'd like to see added to the chapters, and also any other groups that you think that would benefit from seeing this before we bring it back to the board in June for sign-off. You've got the first draft of each chapter attached as appendices 1 and 2. And so far, these chapters have been presented to the Children's Oversight Group, the JSNA Steering Group, and the Progressing Early Help Intervention Offer workshops, which took place last year. So a bit of background on the JSNA design for children and young people. Because this is such a massive JSNA, we've split it out into a pack of chapters that follow the life course. So starting with population context, which sets a scene of our populations in their age groups, then maternity, following by early years, school-age children, and then young people. So we've sort of started with the population context and gone to early years, and the next stage will be maternity, school-age children, and young people. We've also developed what we're calling Spotlight JSNAs to explore key areas further and look at those inequalities. And these are determined mainly by stakeholder surveys and other forums with service users. So you can see there's 6 so far, and those might grow. Looked after children being one of the topics that we are looking at the moment. This is just an update on where we've been and what we've been doing for the last year and a bit. So it's been a bit of a staggered start. We started the work in March 2023, but then capacity issues meant we had to pause the work. And now you can see we're bringing the first 2 chapters to the Health and Wellbeing Board with the view to bring the school-aged children, maternity and young people to Health and Wellbeing Board in September for the full pack to be published all together in bite-sized chunks rather than one enormous JSNA. These 3 chapters have also been started already, so the school-aged children and maternity, and work will continue for the next 6 months or so. As part of the work, we've done a lot of stakeholder engagement to promote that partnership working. We held 30-minute consultation meetings with a number of stakeholders. There's a short list there, but there are more, just to explore what data was already out there, what work's been done, where the gaps in evidence are, and what we need to know as a system, which will inform our engagement in terms of qualitative work and also in terms of collecting quantitative work. And common themes came out of these discussions, which also formed the Spotlight JSNAs as well. In terms of aims and objectives, you probably already know what a JSNA does, but it's a detailed understanding of the needs of our children, young people and families in Shropshire to inform our commissioning and the direction and development of local services with a view to explore those inequalities which exist and look at our impact of early intervention and prevention. For these first 2 chapters, the main aims are to provide a population profile, the risk factors and wider determinants of health, highlight our relevant policies and context, look at those overarching metrics for health for CYPs, our current service provision and where we're doing well and where we need improvement, and then looking at vulnerable groups, gaps, barriers and unmet needs, with finally providing recommendations based on the evidence. I'll now hand over to Rakiba, who will give you a high-level summary of the population and context chapter. Are you there, Rakiba?
Yes, I am. Good morning, everyone. My name is Rakiba Agberami. I'm the Senior Population Health Intelligence Analyst working alongside Jess. And as Jess mentioned, we've worked on 2 core GSNA chapters, which is the Population and Context chapter, as well as the 0-4 chapters. I'll be giving a brief overview of what we've covered in the population chapter, and my colleague Jess will go on to speak on the 0-4 chapter. The slide you're currently seeing gives an overview into the sections we currently have in the population and context chapter of the GSNA. The chapter covers Shropshire's population structure, ethnicity, household composition, as well as Shropshire school population. It also covers some wider determinants of health, such as deprivation and child poverty, drugs and alcohol use, domestic use, infant and child mortality has also been covered in this chapter. I'll just give you a couple of seconds to have a look at the slide before we move on to the next slide, please. The infographic currently displayed on the slide shows you some population metrics for Shropshire at a glance. I won't be covering everything in detail due to time, but it will be good to flag that Shropshire's population has seen a 5.6% rise from about 306,000 people to about 323,000 people. And this is from the 2011 census compared to the 2021 census. And if we look at the population by age, about 48,000 residents are children aged under 15, and this is about 14.8% of Shropshire's total population. This compares to 18.1 aged 0 to 14 in the West Midlands region and 17.4 in England. In general, there's been a decline in children aged 0 to 19 since 2011, with the largest reduction observed in those aged 15 to 19 in particular. There are about 181 schools in Shropshire, of which 15 are independent and 19 are special. And about 16.9% of pupils in Shropshire are eligible for free school meals, and there are about 500 looked after children in Shropshire. Can we move on to the next slide, please, Jess? This slide covers the population change observed in Shropshire between 2011 and 2021. In 2021, there were about 2,600 live births in Shropshire. This is a 2.4% increase compared to what was observed in 2020. And the Shropshire's population, like I mentioned earlier on, has increased by about 5.7% between the two census periods, from about 306,000 to about 323,000 residents. And when we split this by age, the largest increase in population was seen amongst those aged 70 to 74 and 75 to 79 at 45%. And like I mentioned previously, we've seen a decrease in the number of children and young people between the two census periods. And also another important thing to flag is that Shropshire also saw the second largest fall in West Midlands in the share of households, including couples with dependent children. And this was from 19.5% in 2011 to 16.9% in 2021. Next slide, please. So we're going to move on quickly to where CYPs live. Baston Hill, Orwestry East, Market Drayton West, and Wem have the largest number of CYPs, with more than 1,800 living in each of these wards. However, when we break it further down by age group, we can see from the maps displayed that there are variations in the areas where CYP live in Shropshire. For example, the highest number of 0 to 4-year-olds live in Baston Hill, while the highest number of 15 to 19-year-olds, for example, live in Bornell. So this is just a pictorial display of where CYPs live in Shropshire. Next slide, please. On this slide, we're looking at the Shropshire's school population. Based on the recent school census, there are just under 40,000 children in local authority schools, of which 94% live in Shropshire. And if we look at the map on the left-hand side, we can see that the MSOAs within Brownclea, Shifnal, and Market Drayton are the highest percentage of pupils at Shropshire schools. There are more than 1,600 children aged 0 to 4 attending schools in Shropshire, with 75% of these children in the N2 school year. And if we move on quickly to the with regards to school population that requires SEND support, this is about 12.9% of the school population, and 3.8% of pupils have an education, health, and care plan. And looking at the map on the left-hand side, we can see the ward, the MSOA, or the ward rather, shaded dark red. That's Lawton. So MSOAs in Lawton, 10, and Bagley saw the highest percentage of pupils who require SEND support. This infographic covers the wider determinants of health highlighted in the GSNA. For indicators highlighted in red, that means Shropshire is doing worse compared to the national rate. So for example, we have the rate of emergency admissions in Shropshire, which was about 180 per thousand. This is worse than the national rate of 161.5 per thousand. Then if we look at the looked after children indicator, Shropshire had about 161 looked after children aged 0 to 4 as of March 2023. This equates to 2.4% of all looked after children. However, this is higher than the national average of 18%. There are also indicators where Shropshire is doing well. So those highlighted green are indicators where Shropshire is doing well. For example, 14.4% of children aged under 16 live in absolute low-income families. This is lower than the national rate of 15.3. Can we move on to the next slide, please? The image you're currently seeing on the slide basically gives an overview on children aged 0 to 19, basically their health and well-being in Shropshire and how it compares to England. I'm just going to pick a few of these indicators, those that were doing well and those that were doing not so well in comparison to England. For some of the indicators that we're doing well, we have the A&E attendances for 0 to 4-year-olds. For example, in the the period 2022 to 2023, Shropshire's A&E attendance rate was about 617 per 1,000 population. This equates to about 8,700 attendances amongst children aged under 5. This was significantly better than the regional average as well as the national average. And if we look at the birth weight of 10 babies, in 2021, 1.8% of infants were born with a low birth weight, and this proportion was better than the West Midlands average of 3% and England average of about 2.8%. But then if we look at the indicators where Shropshire is worse in comparison to the national average, we have the smoking status at the time of delivery, for example. 1.4% of women in Shropshire were known to be smokers at the time of delivery, and this proportion was significantly worse than the West Midlands average of 9.1% and the England average of 8.8%. And if we look at one more indicator, which is the 16 to 17 not in employment, education or training, we had about 7.9% of people aged 60 to 17 not in education, employment and training, and this was higher than the national average of 5.2%. So this is basically some of the indicators we've got highlighted in the GSNA population and context chapter. Lastly, we've got the infant and child mortality rate. For example, on the graph on the left-hand side, which is for the infant mortality rate, there were about 37 deaths under 1 year of age in Shropshire, and this equates to about 4.8 per 1,000 live births. For Shropshire, this was the 6th lowest regionally, and this was similar to the regional rate of about 5.6 per 1,000 and the national rate of 3.9%. And as you can see from the graph, the blue line is for Shropshire. There was an increase in infant national rate between 2014-16 and about 2018-20. However, we can see that the rate is beginning to sort of flatten off from the graph displayed on the left-hand side, and for the graph displayed on the right-hand side, that shows the child mortality rate, and as you can see, there's been a jump in child mortality rate between the periods of 2019-21 and 2020-22. And I'm sure Jess would mention this when she goes on to talk about the 0 to 4 chapter. There's now a deep dive into this particular indicator. So we're carrying out some analysis into these particular indicators to see basically what's driving the increase in child mortality rate in particular. So that's it for me. I'm going to pass on to Jess, who would talk about the 0 to 4 chapter.
Thanks, Rakiba. Just to build on that, Shropshire Council has held multi-agency workshops across the Shropshire Telford and Wrekin patch to address the rising trend, because we have seen the trend continue to rise for child mortality, to identify those modifiable risk factors that are associated with the deaths, and also look at inequalities and how we can prevent these in future. So work is underway, and there is a dashboard in development as well. So it's definitely being looked at, even though we've got that rising trend. And moving on to the second chapter that we've brought to the board, the 0 to 4-year-old chapter. As you can see, this is just to demonstrate that we've got a lot in these chapters, which is why we split it out. From this, you can see there's high-level summary statistics, so key stats, which we've pulled from OHID's fingertips early years profile to give us that sort of high-level overview of where we're doing well, where we need some improvement. Then we looked at local data from our service provider, Shropcom, to see what the more recent trends are looking like and where action has driven change. And then lastly, we looked at a bit of a deep dive into vulnerable children. So children need, looked after children, some children's social care data, and as well as including that stakeholder engagement and service user or parent and carers engagement. So just like the population one pager we've got earlier is 0 to 4 infographic that tells us a lot about our 0 to 4-year-olds on one page. So in 2021, we had just over 14,400 children, well, babies, infants and children aged 0 to 4. And that's an 8% fall from 2011. And that's what we also see nationally, so it's not surprising. 4.5% of our Shropshire population are aged 0 to 4, which is slightly below the national figure. And again, we already knew that, but it's compared to 2011, it's changed ever so slightly and gone down. We've got an even split of male to female almost, so 51% male, 49% female, with 3.6%, so a small percentage from ethnic minority groups other than white, but still equating to 567 children. And we had 290 0 to 4-year-olds with SEND support recorded in 22-23. It's also worth pointing out that overall deprivation is low in Shropshire, but we do have just over 500 children aged 0 to 4 that live in the most deprived LSOAs in the county, and those are located in, unsurprisingly, areas like Foregate, Central Oswestry, Monkmoor, Millbrace and Ludlow East. The map on the left, Rakiba's already sort of gone through the previous slides, so I won't cover that. But these icons that you can see and different metrics are colour coded based on how we relate or rank compared to the national average. So you can see a lot of red there, which obviously is a bit disheartening. But when we look at the more recent data from our service provider, we're seeing a lot of improvement, which I'll show you in the coming slides. I won't go through the deaths and the low birth weight because Rakiba's gone through that, but it's just to flag that our biggest gaps really are for our breastfeeding rates, our 6 to 8 week review and 12-month reviews, the gap is closing. Our 2.5-year reviews is where we need to improve, and we are similar to the national rate at 22.1% for children overweight or obese. Our MMR vaccination coverage is below the target of 95% at 89.8% currently. We've also included policy and guidance, and I won't talk through this too much, but we have, of course, included Best Start for Life and the Healthy Child programme, and there are some new action areas and recommendations in that Best Start for Life policy, mainly around the family hubs and the Start for Life continuing and really pulling together all that integrating of services. This high-level summary is essentially what is on that one pager that I've just shown you, but just to point out a few extra metrics that aren't on that one pager. So Rakiba mentioned smoking status at the time of delivery. So we are at 11.4%, higher than the regional and national average. So that means 1 in 10 of our pregnant women are smoking at time of delivery, which there's a lot of work being undertaken to address that. Our A&E attendances for 0 to 4s is also, oh, sorry, that's green, but also even though we are better than the national average, it still means we have over 8,000 A&E attendances for children under the age of 4, which is obviously not good news. Emergency admissions are where we're worse than the national average and higher. So we had just over 2,500 of those in the latest year of data, and a rate higher than the national and regional average. I think that ranks us for just mid-table for the region and third lowest among our statistical neighbours. For smoking at time of delivery, we are third highest regionally and highest among statistical neighbours. So in terms of where we're red on this chart at a glance, that we can quickly see our needs, and I'll highlight where we need to direct action. These are our mandated health metrics, health visitor metrics that you can see in a long list here at the bottom for half this table, which we are red for in 22-23. But if we look at more recent data from our provider on this slide, it shows a much more improving picture, and which is encouraging. So we've got all those mandated contacts on this chart. You can see there's upticks in the most recent 2 or 3 quarters, and work's being undertaken to keep that continue to rise. So whilst we were red in 22-23 for that financial year, we're hoping that for 23-24 we will go green for new birth visits within 14 days, 6 to 8 week reviews, 2 to 2.5 year reviews as well, and continue to rise. We've also got a rise in breastfeeding rates that's coming up a bit, and that 12-month review as well is on the rise. The reason that we've got such a high rate for 12-month reviews by 15 months is mainly due to the timing that invites are sent out and when those appointments actually happen. So work's being done to change how that system generates those appointments, and hopefully that will close that gap. Moving on to breastfeeding, as I said, we are on the rise. So we've done quite a substantial jump from Q4 21-22 to 32.9%, but we're still below that national rate of 49.2%. And if we look at the percentage of infants not receiving their 6 to 8 week reviews, so no record of what if they're breastfed or not, that has been falling at quarter on quarter, and we're seeing a rise in those partially registered breastfed, but still some work to definitely do in this area. Healthy Start vouchers. There was a Healthy Start voucher scheme that took place in 21 to 2023, and the rate was improved from 49% up to 64%. So a really good success story there. And we can also see that the numbers that are eligible is in the purple line, and those that uptake in green, that gap is closing, which is what we want. with a rate at the moment of 71% uptake, although that is now below the national average, whereas before we were above it. So, but that was probably because of that driven action between 2021 and 2022. We've done quite an in-depth look at vulnerable children in the 0 to 4s chapter. We know we've got a rising trend for children looked after. It's known across the council and across the county, and that's for all ages up to 2023. We know we had 656 children looked after of all ages. And when we split this out to different age groups, we can see 20% of those were aged 1 to 4, which is higher than we see nationally at 13%, and also 23% age 5 to 9, which is higher than that 18% age group. So the Spotlight JSNA that will look at this will deep dive into those wider determinants, the risk factors, and also any modifiable factors that we can do for prevention. We've also included early help hub data to look at those episodes of families in contact with the service and what they're coming in for or who they're in contact with. So secure housing is up there at 30%, 29% of them were children safeguarding, 19% were financial, and 12% health, and some lower percentages for domestic abuse in early years. And that was between May 22 and 23. And then Compass also provided us with some data, really insightful. 74 babies, infants and children were supported by the team between September 22 and March. So it's a 23, so it's a 6-month window. And that included unborn babies. 65% of those 74 babies were aged 2 to 4, so quite a substantial amount in this age group. And the presenting issues were 16% were domestic abuse, 13% parenting difficulties, 12% neglect, and 10% adult mental health. So you've got quite a strong theme there of neglect and abuse and mental health as well, potentially for parental. We've included social care contacts and referrals as well in the JSNA. I'll look at just the contacts here rather than referrals as well, just to give you an idea of what's in there. We had just over 2,600 contacts during 23-24, a slight fall compared to the previous year. Whilst that was a fall, we have seen a rise in contacts coming in from school or having contact at schools, local authority services and A&E. So some work has been undertaken to see exactly why, how and when that's happening and dig into those inequalities there as well. And then lastly for me, the qualitative data. So we ran an online stakeholder survey, I think it was last year, and we had 36 responses with quite a range of different stakeholders participating. Sorry, I heard someone speak. I'll carry on. So we had a fairly good response rate, but not huge. And we've got our strengths and gaps there, but we asked essentially our stakeholders what they thought was working well, what needed improvement. And it was quite an in-depth survey, so it's definitely worth going to look at those results and seeing how we view our system as a collective. But what came out of there is multi-agency working is a strength, online support and home visiting, but our gaps are particularly around that lack of transport, access, rurality, face-to-face contact, and breastfeeding support, antenatal services. So it's a definite strong themes coming out of that one as well. I'll just pass you back to Rakiba for this bit of the presentation because she ran the survey, so has more insight into it.
Thanks, Jess. So we had a service user survey at a parents and carers event of 0 to 4-year-olds. Unfortunately, we had a really low response of about, I think it was 17 people. So definitely we're working on trying to get more engagement with regards to this particular survey. But when analysis was carried out, one of the questions that was asked was, when would you have most and least benefited from the support of a health visitor? And as you can see, 5 being most benefited. As you can see from the different experiences, quite a lot of people benefited from an health visitor during pregnancy, in the first 14 days following childbirth, between 14 and 30 days after childbirth. The numbers or the proportion sort of decreases when we asked people in particular with the experiences for baby aged 6 to 8 weeks and baby aged 3 to 6 months. But when we look at the percentage again, it begins to increase for those aged 12 months to 2 years, child aged 2 to 3 years, and child aged 3 to 5 years. So those were the areas where people felt they most benefited from the support of a health visitor. And when we asked parents what was the most important considerations to them to help them look after the child's health and well-being, these were the the responses. So basically access to healthcare without a long wait, being able to access services for information and support without delays, and of course, physical health nutrition, followed by the mental health well-being of the child and how to support the child, basically. So things Jess had already flagged in the previous stakeholder engagements that she spoke about earlier on. We're looking at getting the numbers in terms of the response rate, trying to carry out the survey again to see if we can get a more response. But however, this is what we have at the moment. Thank you.
Okay, and then lastly, next steps. So we are in the process of developing recommendations at the moment with Anne-Marie and Paula Mawson, and collating feedback from the groups we've taken this to. And we really just would like to know if there's any gaps that you think in these first 2 chapters, or any other groups that you'd like us to take these to before coming back for sign off by the board in June. Thank you.
Jess, Rakiba, thank you. Probably worth taking the slide down and being on screen, if that's okay.
Sure.
So, I mean, the first bit for me to say is this is a really understatement of the morning, probably comprehensive and significant piece of work in a level of detail that is really extensive. So thank you both for the work and effort and presenting it this morning. I can see hands have gone up already, which is fantastic. But I just wondered, Councillor Hurst-Knight, Kirsty, whether you wanted to comment on this first as the portfolio holder.
Excuse me, I've got another snoring dog underneath me, as always. No, extensive work. I've made lots of notes, and thank you. Really interesting read. And you know, when you see the slide and you see the reds and you think, oh, but then when you see the work that has been done is immense, really. So please pass on my thanks to the teams, because I know there's been so many workshops and different interventions, and it shows by trying different things, look at what we've actually achieved. So I know a lot of this falls under Councillor Motley's portfolio. It's kind of a crossover, but it's just really heartening to see all the work that's coming together. So thank you.
Thank you, Councillor. I didn't see whose hands went up first, so I'm going to, Tanya, I'll go first with you, if that's okay.
Thank you very much, Chair, and thank you, Jess. I chair the Shropshire Children's Safeguarding and Protection Oversight Group, and Jess and the team went through this in great detail to the partnership, and it's good to see there's been some changes to the report. So yes, Simon, you're absolutely right, comprehensive report, and a report that must not sit on the shelf, colleagues. I think I'm always concerned when we see such a great report like this that we don't allow it to sit on the shelf and don't take action on it. And I guess the area of greatest concern that this system should be concerned of today is the 0 to 4 data, which Jess went through. And obviously we are concerned about the 22-23 data in terms of Shropshire being an outlier in terms of 6 to 8 week check, 12-month review and 2.5 reviews. But I am assured by Jess and Shopcom that data has improved in 2023. What we've asked for is that to be monthly reported rather than quarterly, so that we can keep a really good check on that, because we know that if we identify our families early, then we can support them in a different way and prevent those children coming to harm, and the need for the local authority to sadly bring those children into care. At the Children's Safeguarding and Protection Oversight Group, we talked about the dental data and the concern around the number of children being admitted into hospital for dental treatment. And Jess has agreed to kind of look at that data to see what else we could be doing in that area. I guess the other concern to highlight is the overweight in reception age. And I guess with Jess, we'll see a recommendation come through there. My final comment would be just to ensure we've got consistent use of data. In the early part of the report, we talk a lot about England average and West Midland average, and then we later then talk about statistical neighbours. We know that Shropshire is very different to our West Midland colleagues. It's important that we recognise that in terms of rurality and deprivation, and that we know that we are currently seeing in Shropshire. Thank you.
So Tanya, you covered a number of bits that I was going to highlight as well. But on your first point, because I could see several people nodding at that, and so Jess, Rakiba, Tanya, colleagues, the key bit. So I agree about this can't be a report that stays on the shelf or on somebody's shared drive as it is now. The risk is the amount of information and data that you open it and think I'm overwhelmed by this, and where do I start? And so I guess the challenge, Tanya and Jess, is how do we make some of the elements so user friendly so that people can go in and understand that? So some of the areas, you know, so the charts that show the benchmark piece and that show the reds and the ambers and the greens, and then the you know, almost a hyperlink from there into the right bit that gets you into that space. I'm just thinking about how we might use some form of web-based format that would enable people to explore and use in a way, because my fear would be you would open the cover, you would look at the first contents page and think that's it for the document, realise that's just for the first couple of chapters. And so it becomes overwhelming and you risk not using it, not because the work's not fantastic, but just because you do where do I start with this and how long have I got to try and get to the right bits? I've not got an easy answer to that, but you know, that was my bit as I was reading through it, you know, when the papers were published, was if I was using this from a programme and project piece of view, how could I navigate this easily to get to the right place? Jess, you got your hand up.
Yes, totally agree. And I think that's the biggest risk with JSNAs that are a population JSNA rather than a theme. But what we did for the drug and alcohol JSNA was do a slide deck that was a summary. So I think it was 10 slides that basically pointed you in the right direction of what chapters you would need for certain issues or different things you want to look at. So that is the aim, is we'll do a slide deck per chapter. So you can pick up the summary slide deck and think, okay, I can dig into the detail in the main report. So that could be a way around it, potentially.
I think that was really helpful. I've got other hands that are coming up, but Guy, your hand, I think, was linked to this point. So I'm going to jump others and bring you in, if that's okay.
Yeah, thank you, Chair. It was purely on that, the use of the infographics. I've done our community risk management projects for the last 4 years and the next 4 years. And I'm the one who has to go trawling through some of these documents. So that use of a high level infographic, even if it then takes you off to more detail, is absolute gold dust for anybody that is looking to sort of take the bits out of it that they get lost.
And I think, you know, Jess, Tanya, colleagues, the bit we'd agree is actually we want partners going and exploring and looking and following up. And then even if it comes back with and I don't fully understand this, what does this mean? Because that's triggering the use of it. So, you know, from a police perspective, fire, voluntary community sector, we want this to be used, not this is an amazing piece of work and the Health and Wellbeing Board endorse it and here's the action plan. So I think that bit of slides, help navigate, bring out the highlights, then send you into the detail. If you want further detail, you can then choose which levels you go at. I think that'd be really helpful. Claire, then Nigel.
Sorry, I've got a few comments. Fantastic piece of work, and with my interest in children and young people, it's just brilliant to see. So thank you for that. I think firstly, there's lots of links with different things that we're starting to talk about, travel, housing. So I think, you know, having those joint conversations is really, really helpful. The Healthy Child Programme, it's good that the visits are going up, but the bit for me is what is the value of those visits and how do we get assurance that the right conversations are happening? How are we encouraging the uptake in vaccination rates? How are we managing things like nutritional information? How are we managing stop smoking and those sorts of things? So great to see them going up, but I think we just need to think about how we start and look at that. The other bit about breastfeeding, again, it's going up, but how assured are we that women feel comfortable breastfeeding anywhere? I must admit, I don't necessarily see signs up, and probably in doctor's surgeries and the hospital, that ought to be the first place we should be seeing those, but I don't see them around town or anything like that. So I wonder if we could think about starting to campaign with community pharmacy and all our other primary care services about that. And then the other bit was around just a very small point, the GP access that's in the report about 15 minutes to get to. That seems quite a short amount of time to demonstrate the issues around rurality when buses take 2 hours sometimes. Because to be honest, if I got public transport when I lived in Birmingham to get to my GP surgery, that would have definitely taken longer than 15 minutes. So I just wonder if that's quite a short time frame to really demonstrate the challenges of rurality in Shropshire. And then, I mean, there's loads of other things. It's fantastic. I'm getting all enthusiastic. So those were my main points, I think.
Thank you, Claire. And so, we're going to talk later on in terms of the ICB update, joint forward plan, the refresh of that. So how we use the data to drive that integration strategy is all going to be really important. This is Nigel, then Lynn, then I'm going to bring this section to Rachel.
Without repeating bits, so one of Jess, one of your requests was in terms of anyone else we need to speak to, and I know your list of the stakeholders was significant, and then it said and more. Can I just double check whether the local maternity and neonatal system has been one of the stakeholders?
Yes, we did speak to them. Yeah, we did.
It's just that I think with some of the, where Claire and yourself have mentioned things like breastfeeding, smoking at time of delivery. I know that's been a really significant bit of work, and also with some of the specific areas around, our core 20+5 work with maternity. That's a real hotbed. But please let me know, and obviously I think it's Vanessa picking that up from an ICB. Vanessa Watt is our chief nurse. Then I know that if there's any specific areas or you would just want to double check anything for publication, I think that would be really useful. And the second bit was just picking up Tanya's point really about how just we make sure, clearly there's a range of things here that, Tanya, yourself and others will absolutely be driving. But I think the work that we're already doing jointly as a population health management group and also a prevention health and equalities group, then if there's opportunities there and the offer of those sort of summary slides of the key areas, that might be the place to start. But certainly I'll be taking this and just making sure that Tracy Jones and key people that work on health and equalities are. Tracy, I didn't even see you were there. So you've been going like this all, yeah. I've got a paper copy here really. But I think that's I think one of the opportunities of making sure that we just bring it to life. But clearly, this is wide ranging, so we just need to identify the right areas of opportunity. But I think those are two key groups, and Rachel and I work really closely on that.
Thank you, Nigel. So Lynn, then Rachel, and then we'll move on.
I just wanted to pick up on the point that Tammy made touched on about dentistry. I know it is part of a later paper, but we did a piece of work around access to dentistry, and we did pick up on some of the issues, particularly around children's access, and that is continuing to be something that we're hearing about. So people are really struggling to get an NHS dentist for their children, and sometimes the conditions on that place are a challenge. So practices might say that they will only take a child if they can also take the parents, but the parents aren't offered NHS dentistry in that practice, and they're worried about the expense of their own treatment. And so we know that there's a lot of children who are not accessing dentistry just because of the way the system is preventing them from doing it. It's not because their parents do not want them to access that service.
Rachel.
Yeah, thank you. Just a few final points. So firstly, massive thank you for all the work that goes into this. We can't underestimate it, but how important it is to inform the decisions that we make, which I think is the point that everybody's made. It doesn't just sit there, it informs our commissioning, it informs our service planning. The recommendations will be critical, but they need to take account of the action that's already taken place, because I think we've identified lots of issues. And I guess the board needs assurance that actions are taking place, or that we're filling gaps and making sure services align. There's lots of overlaps, and I think so there's a piece of work for us, I think, to do with the recommendations when we bring this back, but also in terms of understanding the actions. Just picking up a couple of them, particularly, you're absolutely right around the 0 to 19 service. That will be picked up in other chapters as well. We have improvement plans in place, which is why you're seeing some of those improvements, but being open, transparent through the various groups. We've got the joint commissioning group, other groups that need to have sight of the actions that are taking place, to have that assurance. But some of this is system-wide, as you rightly said, Claire, around things like breastfeeding, smoking and pregnancy, and that links to me to the modifiable risk factors that then you see overarching as our infant mortality. So we mustn't lose sight of that. I think what I would say is before highlight some significant areas. Mental health we haven't picked up on, but there is in the report if we look at that, and I think some of it, that is really critical. You can see the numbers are starting to rise in terms of referrals, people's concerns around mental health, and our children and young people that are picked up. So I guess just to conclude, to give some assurance to the board that actions are taken place, we need to monitor those, and I think it's right that we bring something further back to the board to assure you that actions are being taken where we're identifying areas of concern, areas we need to do more, and then our role is obviously to make sure we fill some of those gaps and do more. So I just give assurance, and I'm happy to bring a further update when we bring through the final report.
So I think it'll be really helpful, and but bringing through at that point the summary slides as well and showing all that together. So Rachel, Tanya, Jess, you could work in terms of when's the right time to bring that back in the right way, but let's not partners wait until we've got the perfect version before we start using this data to think about what we're trying to do with our services. And so that's really appreciated. Thank you for that. Jess, Rakila, you're more than welcome to stay for the rest of the meeting, but I will understand if you choose to drop off as well. I should have said at the start that those observant in terms of the agenda, and you gave the perfect segue, Rachel, in terms of the areas for discussion this morning, is focused around children and young people. So it absolutely made sense to start with the JSNA, when now we're going to go into the children and young people's mental health transformation plan. So the theme, I should have made this clear, but I'd assumed that by people looking at the agenda would have spotted that anyway. This morning is around a focus on children and young people across Shropshire, and we know there are areas where we need to do significant work and we can improve things, and that context that's just been set for us there is really helpful, I think, as we get into the next couple of agenda items as well. Vicky, Tracy, Liam, I'm handing over to the three of you, if that's okay. Probably worth introducing yourselves. Liam did at the start because he was on Teams, and then assume papers read, take us through the headlines, and then let's get into the conversation.
Thank you. I'm Tracy Jones. I'm the Director for Children and Young People, Learning Disabilities and Autism and Mental Health for Shropshire, Telford and Wrekin ICB. I also hold the lead for health inequalities across the ICB as well. And I've joined today not only to be in support of my colleagues Liam and Vicky in terms of their paper, but for that very reason that the whole of the agenda and the focus is on children and young people. So I'll be staying throughout the whole of the Health and Wellbeing Board just to listen and to take notes, and really thanking Jess for that presentation, because there's some really key points in that we can look to. So I'll pass to my colleague Vicky.
Hi there, so Vicky Jones, Head of Mission Transformation for Children and Young People, Learning Disabilities and Autism, all age. I'm going to pass over to Liam because he's going to start the conversation and then come back.
Well, thanks all. And we would, if I was in the room, me and Vicky would have planned a little bit of a two-pronged approach, but we're used to delivering in tandem. It'll be a joy to do it by teams. So yeah, Liam Lawton, Head of Children and People and Family Services, for Shropshire, Telford and Wrekin Care Group within MPFT. I wish we'd put this onto a nice little slide deck like Jess had done, but I've just been busy hitting enter a lot of times on the screen to try and have sort of key messages on one bit of the Word document for us, so it looks different to the formatting in the paper, but to talk through it. So I suppose to set the scene in terms of the context, we know that the prevalence of emotional and mental health difficulties for children and people continues to increase and has done for a number of years. What we've got there is a little graph to show the local increase that we've had across Shropshire, Telford and Wrekin in terms of referrals in for mental health services for our children and people across the patch. So a 262% increase, taken from a rolling average from 2020, where we were receiving about 178 referrals per month, to the last 6 months of data that we had when we produced it, which was up until January 2024, where we were seeing 644 young people on average referred in. So a real significant increase in needs of our children and people. Alongside that, not to the same degree, but there has been an increase in the number of active cases. So again, this is just data from MPFT services, but when we talk about an active case, we're talking about a child or young person who's engaged in assessment or treatment or therapy of some description. And again, a big increase in that. So again, the rolling averages are sort of 6 months apart from 2020, when we first started having data as the service, through to where we are now in 2024. So again, 1,200 children and people on average were engaged in that active treatment. They were actively getting a regular service from BU. to now. So that number being, January 2024, that number being 3,233. So lots more young people needing services and lots more young people getting services. But you will notice that the difference in terms of percentages wasn't the same. So we have also seen an increase in waits. There are more young people being referred in than what there have been in terms of a response to them, in terms of those assessments and treatments. And we know that one of the big challenges we've had as a service has been lots of young people waiting for services and increasing waiting times for them. When we move to neurodevelopmental rather than mental health referrals, we see an even starker increase. So our neurodevelopmental assessment team covers autism assessments for 5 to 18-year-olds and ADHD assessments for 6 to 18-year-olds. And we've seen a 767% increase in those numbers. So sort of 2.5 years. So we were averaging for the year 2020 to 2021. So that's the financial year from April to the end of March, 15 a month in terms of numbers of children and people that were being referred for an assessment of autism or ADHD. That figure for the rolling average for the calendar year of 2023 was 130 young people a month. So from 15 a month to 130 a month. So an absolute explosion. And again, we have seen national increases, but 767% is pretty stark in terms of when we benchmark against other areas. So we talked about the knock-on effect, and this is Shropshire Children and People's data from the last Commissioner report. So we share our reports as a provider from MPFT with ICB and local authority colleagues on the last Friday of every month in our contract review meeting. And this is numbers of children and people waiting, and the team's breakdown just tells you which sort of a assessment or interventional pathway they're waiting on. So some of those are quite self-explanatory. So ADHD is young people waiting for an ADHD assessment, and that's 141 children. Shropshire children, there's 394, so almost 400 Shropshire children waiting for an autism assessment. Just over 400 waiting on the BU assessment, that's our mental health referrals. And then for core mental health, that's secondary care, that's treatment. So they've had their assessment, but they are waiting for ongoing therapeutic support or nursing support from core CAMS. There's one young person waiting for crisis. That will be an anomaly. There are no young people waiting for crisis support. They do get seen within 4 hours, but at the time that the data was pulled, there might have been a young person not yet seen. 6 young people waiting for learning disability support. 33 young people waiting for medics, which is our psychiatrists, our medical interventions. Physical health is a really important part of the offer, to look at the physical health needs of our children and people who might be accessing education or might have an eating disorder or might need that physical health intervention and monitoring as part of their mental health treatment. And then we've got some of the MHSTs, which is our mental health in schools teams, so children and people waiting for a lower level intervention, not meeting core CAMS threshold, but getting that support in their school or in their community. So 1,300 just over young people waiting for support. And in terms of how long they are waiting, because again, that's the important bit, and again, it's broken down across the teams, but the median sort of average length of time that children are currently waiting. So this isn't how long they will wait, this is how long of all of those young people. So the 141 young people waiting for ADHD, the average length of wait currently for them at last time of reporting was that they've been waiting 16 weeks. There'll be some young people that were only referred last week or the week before that have only been waiting 1 or 2 weeks, and there'll be some young people who've been waiting considerably longer than that 16 weeks, but the average is there again for each of those. So we absolutely done tons of work in terms of waiting list initiatives and waiting well work. So we recognise that it's not good that children and people are waiting for services, and we've got a duty to ensure they're waiting well, and there's lots of bits of work that we're doing around that. I know Naomi's on, and there's sort of would mention, I'm not sure it's included, work around the social prescribing, which I know is later on in the agenda, but those links, so we've linked up with that project that's being run through or evaluated through UCL in terms of young people waiting on waiting lists who might benefit from something in the interim through that. We've got dedicated assistant psychologists who are proactively calling families in terms of the first step in sort of the waiting list, waiting well work was around sending information to families saying, we're really sorry you're waiting, and here's some resources that you can access in the interim. And the next step to that, and we dedicated some resource to it, we were lucky to have some additional resources provided, was actually let's have some roles of people who can proactively call those families. So it's not enough to just send a letter. We want to actively engage with those people on waiting lists and check in on how they are, offer that signposted information and give indications as to how long they might be waiting. And that's been really well received on the whole, by those few families who are quite cross that we're phoning them to tell them they're still waiting, rather than phoning them telling them that they've got an appointment. So moving into I was going to say next year, this year, April 2024 through to 31st March 2025, we're in a new contract for this year. The 7-year contract that BU had came to an end 31st of March 2024, and we've set some really clear KPIs, and it's really good news. The finance bit isn't in this bit, but the new contract absolutely focuses on those challenges that we've had and that we know that we've had, and we've worked really collaboratively together to say how can we maximise the resources that we've got as a system, how can we tackle some of these real high risk areas that we've got in terms of long waits for children and people needing to access emotional being and mental health support. How do we work together and collaboratively to do that? So some really clear KPIs in our new contract and really clear ambitions about where we want to get to. So assessing children and people within timeframes that, assessing a person with mental health needs within 6 weeks, starting treatment within 18 weeks, which are really ambitious but achievable in terms of the new investment, but absolutely where we need to be, because we've had young people waiting for those routine mental health assessments for 12 months in the not too distant past. So to be saying that we want to get to a point where we're assessing children and young people within 6 weeks is absolutely where we need to be. I should have focused on this first line a little bit more. The children and people's access target for mental health is set by NHS England, and it's worked out by the prevalence of mental health needs within any given community. So for us in Shropshire, it's worked out for Shropshire, Telford and Wrekin, because it's an ICB footprint. There are somewhere in the region of 28,000, 30,000 children and young people across Shropshire, Telford and Wrekin, with, according to prevalence data, who would have a diagnosable mental health need. And our access target, set by NHS England, is to support 8,341 of them. So the way that the access target is set by NHS England is we understand that there's going to be a large number of children and people who would meet criteria for depression, anxiety, OCD, PTSD, whatever it is. And your target is to support about 30% of them. So even if we hit our access target, which again is absolutely the target of seeing 8,341 children and people in this new contracted year, we're still saying there are 20,000, give or take, children and people who have got needs that aren't being met, that aren't being seen. So I often mention it because I think it's sometimes forgotten. I think people assume when NHS England set a target about how many children and people should be supported for a particular thing, that the idea is that that covers off all of the need, but actually there's a huge amount of unmet need there for our children and people, and we understand that absolutely. So I won't go through all of the targets. Some of them are the same as they have been in previous years. We've predominantly met the children and people's eating disorder target, seeing them within 95% of our children and people within the waiting time standards that are specific for children and people who might have an eating disorder. Again, young people in crisis, so an immediate risk to themselves or others because of their mental health presentation, receiving triage within an hour and assessment within 4 hours. And again, we tend to hit that most months, and any time that we don't hit those targets, we provide a breach report that's shared with commissioning colleagues, and and system colleagues at that contract review meeting. So we're absolutely held account to those sorts of things. So neurodevelopmental rather than the mental health side. Again, aiming to decrease those waiting times. So aiming to assess children and people with suspected autism or suspected ADHD within 26 weeks, which is within 6 months. And again, that's a significant improvement to where we currently are or have been as a system. So there have been some changes in the contract moving forwards. So BU was a subcontract, a partnership arrangement, between MPFT as the main provider, the Children's Society, Cooth and Helios. And as I say, that the entire BU contract was due to finish in March 2024. We've extended the contract into the new year, and Cooth and Helios remain as partners in that project, so those offers are still there, and in fact have been enhanced in terms of some additional investment into some of their pathways. But the Children's Society offer is no longer part of the BU contract moving forwards. That was not a decision taken lightly. We did a full review of the quality of that work, the evaluation, the feedback, risks, complaints, accessibility, all of those sorts of things, as well as that kind of cost benefit in terms of how much are we investing in that offer and what other things could we do with that similar level of investment. So Children's Society is no longer part of the offer.
To keep us moving, Liam, because in terms of a gender item and conversation.
Yeah, of course. And I think the next bit is just, I suppose, the good news bit that I want to talk to at the beginning around the new investment. So there's a repurposing of some of the investment that was saved, so the Children's Society investment, but there's also been new investment through mental health investment standards in terms of new monies coming in. And what that gives us is a real opportunity to grow the workforce. So we're looking at an increase of about 30 to 35 full-time equivalent practitioners in the service, which is fantastic. Much more opportunities to work with our system partners, with children and people in their schools, in their communities, and really reduce those waiting lists and waiting times down. And then I suppose Vicky and Tracy, in terms of the next steps bit, in terms of the moving the contract forward into 25, 26 and beyond, if I just hand that over to you, and then I'll close the slides down.
Make mine a bit quick, because I'm sure what we want is a discussion, really, isn't it, around what's going on. So obviously what Liam's been able to present is, I think, the good news story, what we're doing this next year, and we'll see some vast improvement and big changes in the current service. But on top of that, what we've got is a contract extension for 1 year, so we now need to look at what that future longer term model will be. So our next steps now, we're in the process of emails are due to hit people's, and many people around this table will get them in the next week, looking to set up a small project group to take that forward, of which there will be arms around how do we make sure we get engaged with children, young people and parent carers and professionals, but also reviewing what we've already got. I've heard a lot since I've come back to the system of, we've already got lots of rich data. There's already lots of surveys that have happened. I know Health Watch have done some. We've got some going on at the moment with education and in schools. So actually we need to just take time to reflect on what we've already got, pull that together and look where those gaps are and jointly come together to agree that future model. So that's the piece of work. And I would expect in this quarter and probably till July, the end of Q2, our element will be that needs assessment bit of the commissioning cycle, if you like, pulling together what data we've got and going out and looking at the models that we want to take forward. So we'd expect to be there sort of June, July time, which would be great to come back and share those when we get to that point.
That's really helpful, Vicky. Thank you for that. Sorry, hands gone up all over the place, which I would have anticipated with this, which is great. That's why I was keen to get into the conversation bit, because I wanted the discussion on this. Just a couple of bits just to So it's not the Health and Wellbeing Board's responsibility to manage the performance of the contract. So there's routes to do that. So let's make sure I'm sure none of us are going to get into that space anyway, but let's not fall into the contract management conversation. Let's talk about how does this link to what we heard in terms of the GSNA, and then what are we doing differently? What does that look like going forwards? Having said that, one minor point for me is I always get slightly twitchy when I see median weeks and waiting times. So without a range to see maximum and minimum. So anytime we have a medium table, please can we have a maximum and minimum, so then actually you know what the level of time is for worst weights in that space. There's a risk that median masks a lot in a single set of numbers. So there were hands up, someone gone.
That's my exact question, Simon. That was median. So
Tanya.
Thank you very much. So just noting that nationally there's been a huge increase in demand across mental health provision for children and young people, and we've certainly seen that in the Shropshire system. For the Shropshire Health and Wellbeing Board, I think it's really important that any papers that come to this board are Shropshire focused, and there is one table was about Shropshire data, but I'll be really keen to see what was the increase in referrals to the Shropshire children and young people. So we're saying we've seen a 262% increase in CYP referrals and 767% for ND. I'd like to know what that was like for Shropshire, please. And also for us again to just please looking at statistical comparisons, because again, my previous point is the same in that we can't compare ourselves to Dudley and Telford and Wrekin. And we've got specific issues living and working in a rural county like Shropshire. I've got a number of kind of contract stuff I'm not going to raise today, but I think somewhere in all of this, we really need to ensure that we're monitoring those KPIs on a regular basis. Great to see the reinvestment into BU, and obviously we'd really support that as a Health and Wellbeing Board. I note the increased offer for schools and communities across Telford and Wrekin. Be helpful to know, Liam, just to remind Health and Wellbeing Board, the offer to the Shropshire schools and communities, just to make sure that investment is being spread out equitable. The comment about medium is being picked up. We know there are very high waiting lists for children and people currently in the Shropshire system, and it would be unfair for our families to think that we've not picked that up on. So in future, we must know that, please, as a Health and Wellbeing Board. Yeah, I think that's my main point. Thank you, Chair.
Okay. I'm going to take the comments and I'll come back for Vicky, Tracy, Liam pulls together at the end. So I think it was Liam and Rich.
Hi, thank you. Just a few points from me. The first thing I really welcomed was hearing the work being done about the waiting well. It's the thing that we as Health Watch quite often identify as a need. So many different services. And I was just thinking, when I was a little kid, a 6-week school holiday felt like 3 years. And so when we're thinking of some of these timescales, for that child, that young person, it feels like forever. And when we did our piece of work around crisis services for children and young people, the people that we heard from felt that unless they were in crisis, they were going to not get anything. And so they were talking about being suicidal in order to get services at times, which is a place we do not want any child to be at. The thing I was also picking up on was that unmet need. We know that people place a huge amount of importance on a diagnosis, but if we are not going to offer a service, then it's about giving people information. And I was thinking, a bit like making safeguarding personal, a bit like trauma-informed workforce, we need to have a mental health informed workforce across every part of our service, every part of our system, because we as human beings have to be the people who provide that support. We can't rely on the NHS to provide it all. And mental health affects all of us. So, you know, I just think we need to have a community that can understand and support young people with their mental health and remind them that it is not unique. It is something that we all experience, and we're not medicalising it all the time, because we all have mental health problems, and it doesn't mean that there's something wrong with us. And I'm very, as you can see, I'm very passionate about this. So yeah, for me, it's that unmet need. How is the system? Are we supporting everyone beyond that diagnosis, whether it's a positive diagnosis or not? And so I'm really keen to be part of the conversations about this. Thank you.
Thanks for that, Lynn. If we think about then, partners sitting around the table, work fire do, work police do in this space, that's absolutely about the impact we have on children and young people, but with or without a diagnosis and with or without a condition that somebody says you're getting treatment for this. It's about how do we have a positive impact on our children and young people as a partnership, and I would support that, endorse that fully. This is not just about what can the NHS do in terms of treatment, it's actually how are we starting to turn the dials in terms of the opportunities we give our children and young people across Shropshire. So I've got Rachel and Penny, and then I'm going to move us on. We are a little bit behind. I'll catch up in the next section. I wanted to make sure we spent the time in these three areas having the conversation that's taken place.
Thank you. So just a couple of points from me. I think in addition to the data that we're talking about, I think the breakdown is really important because of the inequalities element here. I think we're not really picking some of that up in the kind of high level figures. So where variation, particular groups affected, and looked after children, vulnerable and vulnerable. So I think that would be important if we can include that. I get that, yeah, absolutely, this is not the place for the assurance and the performance monitoring conversations. However, there is a level of assurance I think we as a board need to feel around the direction, and that's why it's important to keep this on our agenda. I think it's been some time since we brought this back here. I know it's been looked at in scrutiny in various meetings, but it is important that we have that assurance that this is moving in that direction. The needs assessment piece that you talked about, I absolutely want to hear the voices of young children. I think the previous bit on the needs assessment, we need to make sure it's one and the same. It's an enhancement of that piece of work, that it's meeting your needs to inform the commissioning of the service, not that we're doing separate pieces of work. I'm sure that's what we're doing, but I just think if we're not quite meeting that in our needs assessment, then with Jess and the team, we need to make sure because we're one and the same. I think welcome the fact to jointly agree the future model. I think the critical bit I'm going to say you'd expect me to say is as a board, we are, and one of the investments through the BCF and others is around prevention, and the prevention part of this, you look at the number of referrals, you look at what we've just heard about in the GSNA data, we know that mental health is growing in our adults and children and young people. It's a real issue. It's, yes, we need people on the waiting list waiting well, but we need to prevent people coming into the services, and when people are on the list, then support them, which is the waiting well bit. So it's primary and secondary prevention. The new model and what we commission absolutely has to support that. And I feel we said we'd left shift. We said through the GFP, we said through the Health and Wellbeing Board, we'd start to put more emphasis on that. And I'm not seeing that in what we're talking about in some of the commissioning and recommissioning activities. So I guess my ask is that we make that happen, and we're really transparent around that. I don't think there's enough around prevention. Don't think there's enough about supporting people so that those numbers stop growing. And I think that's the concern, without going into all the detail here around the parts of the contract. And that's where things like, we're going to come on to it in a minute, children, young people, social prescribing, was absolutely trying to stem that flow, and we need to put more investment there. And so that's my happy to be involved, but I had to put that kind of on record, I think, from my perspective.
Rachel, thank you. Penny?
Really was going to say something really similar, so just, sorry.
Please, thank you.
Yeah, just was going to say something really similar and just echo that. I mean, we've got the next presentation, which is around children, young people, social prescribing, which does have a look at that real preventative element, but actually it's a significant contract in the system. And actually, I would think that as a board, as a recommendation for me would be around looking at a more holistic piece around how we're investing in prevention, but also how we're integrating as part of that. So from the prevention side right up to the emergency response, because there's, a young chap in Shrewsbury was saved because of the quick actions of a police officer there in the library, and those things are happening. So from the prevention right through to the crisis, that's what we should be talking about, I think, and also directing us as commissioners to make sure that we are spending the right money in the right place. And if you're talking about 20-odd thousand children who aren't having anything, they're not having that, the point of when they need it is the point when we should be making sure that something is available, whether that is they have someone to talk to in school, a teacher, and going back to Lynn's point about everyone
everyone being mental health informed, and they know that they have someone safe to speak to. That's the trauma informed approach. So bringing all that together as part of this and investing in it. And this is a sizable contract, so I do think it's a place to have that conversation around this contract.
Thank you. I can see I've got a hand up online on Teams as well. Sorry. Final comment, and then I'll come across to Vicky, Tracy, and Leah.
Thanks, Chair. Just very quickly to say, MPFT are also doing a needs assessment around neurodiversity. So, you know, a full analysis of our data, an evidence review, also some analysis of our waiting lists across the board. So just going back to Rachel's point in terms of kind of lining up those bits of work with the CYP, JSNA, there is resource and expertise being committed by MPFT to look at that in some more detail. We could come back to that at some point and share that, but certainly need to make those links with the CYP, JSNA, and also just to reinforce that point that some of these are sort of population level societal issues driving demand, aren't they? And it is really important that we look at that whole picture, not just the kind of service provision.
Thank you for that. So Vicky, Liam, Tracy, final comments, and then we'll sum up.
I'll come in first. I think Tracy will definitely add to it. I think there's two bits that probably haven't made clear enough in here. So there's the element which I really support everyone. I think all the comments that are made, we need to make sure go in that group for the new model. It's not just what we commission, it's how we come together and what's the new model moving forward. How do you make sure we cover all those, the tiers that, you know, we talk about the I Thrive model, but I'm not sure we're necessarily all working towards it or using it well. And separate to that, we are looking at the ND work stream separately, as it's more of a diagnosis service rather than a mental health service. And I know at the moment, and me and Liam have talked quite avidly about this, that BU is seen as both. So quite often when I've gone out to talk to groups, what I get is a lot of feedback around children waiting for an ASD assessment, whereas I want feedback about mental health services. So it's going to kind of go, we're going to do it as two separate things at the same time. So we can split those conversations. So we make sure one doesn't get more emphasis than the other, which we know has happened in the past as well, which I think will really support our system to getting a better joined up model for the mental health, emotional health and wellbeing.
I just wanted to add that we really recognise the point around prevention. But when we've looked at what we're going to target in 24-25, we look at those excessively long waits, and that's really going to be our focus. Quite often we try to change services by saying that we're going to address everything at the same time. And we know that our historic performance in doing that is, well, we don't have a very good track record when we historically say, well, we need to improve everything, let's improve everything. So in 24-25, we're really targeting down on those long waits. We will, of course, be at the same time working around the prevention elements, because that's actually, as we think about supply and demand, that's stopping that need, that supply that's coming in. And then, as Vicky has been describing, as we start working for the 25-26 contract, we will hopefully then be in a more sustainable position, because we have one pot of money, really pleased that it's a larger pot of money, but for 24-25, there's a real importance in addressing those longer waits. So we're going to focus on that, but at the same time, work towards the more sustainable model for 25-26.
Thank you, Tracy. You're getting into a whole analogy that Nigel said very time from waiting list management from an NHS perspective of rear gunning, which is tackling the long waits and the tail end, versus how do we do the middle at this, how do we do the total amount waiting as well as bring down the long waits. But before I go further into that, my thesis on waiting list management, Liam, and then we'll move on in terms of that final comment, Liam.
Yeah, absolutely. I suppose it's following on from what Tracy's just said in terms of actually when we think about our children and young people, everything that we do is early help and preventative in some way, because if we can make a difference while a child is referred to a mental health service and they're having their first presentation of anxiety, depression, OCD, etc., then offering them that treatment, medication, support, whatever they need to overcome that mental health difficulty prevents them from becoming an adult mental health patient in terms of the longer term view. So whilst absolutely emphasis on prevention and whole system working to address children's emotional wellbeing and mental health needs, seeing that young person who is on that waiting list for specific treatment is in and of itself a form of early help, because we are, getting in there early whilst these people are children, to hopefully give them much more better life opportunities and a much better forecast into the future, into their adult world.
Thank you for that, Liam. Thank you, Vicky, Tracy, Liam. Health and Wellbeing Board are asked to receive the update and notes the changes being proposed, support the in-year development of the new model of care for 2025, and continue the multi-agency support to develop the joint services during 24-25. I think the board did indicate their support on that, with a couple of caveats, which was, let's make sure we're specifically highlighting the Shropshire data, so we understand what's going on between the two local authority areas. Let's make sure when we're looking at the data, we understand we look at data in a way that it informs both the long waits as well as average numbers within there. We note the additional investment that's going in and the additional KPIs, but the monitoring of those KPIs as a partnership to really drive that improvement and continue to work together in that space is really important. And the engagement of our children, young people and partners in the shaping of services and the service development and the contracts going forward is really fundamental. And we do this in sight of the GSNA work that we've had and the prevention work that's ongoing as well. That would be, for me, what I think I've heard from the Health and Wellbeing Board conversation. I'm going to move us on, if that's okay.
Just going to
You're not on your microphone, please. I've got the power to cut you off, but I'm not going.
I'm really sorry to interrupt. I'm just thinking of the many people who've obviously contacted Health Watch about issues around waiting lists. I'll just throw this out there.
Children and young people waiting.
Children and young people's waiting lists. So I think it's about thinking of parents and carers as partners within this system, and as they can help with some of the solutions. So, for example, we know that there's some parents who are able or willing to pay for an assessment for their child, but they're concerned that if they do that, that will not enable them to access NHS services. And I think this isn't just about children and young people's mental health, but it's a bigger picture about how we work with people who want to help, but they're worried that if they take it on, they will never be able to share that sort of ownership of their care.
So adding that into our common engagement in terms of impact on what we do, making sure we don't widen health inequalities as a response of doing that, but supporting parents and carers to play an active role and is a really key part. So thank you for flagging that, and colleagues will take that on. I'm going to move us on, if that's okay. Thank you very much indeed for that. So I'm going to move us into the children's social prescribing bit, and then for the second part of the agenda, I'm going to require some help from presenters to help us get back on track in terms of time. But I'm hoping colleagues and board members are recognising that the value in these conversations and me letting these run for slightly longer than we've got on the agenda. So who am I coming? Sorry, yes, I was looking up at the screen because I can see the slides that have gone up. But Claire, I'll come across to you.
Thank you. So I'm going to give a presentation on social prescribing for children and young people, which we deliver in Shropshire. My name is Claire Sweeney, and it's delivered by the Healthy Lives team here at Shropshire Council. I'm going to start first and foremost with the voice of the children and young people, which I feel is paramount. So young people have told us they felt listened to and heard, valued and respected. I've never felt pressured. You have helped me believe in myself more, which is helping my confidence. Been able to interact with others better. You listen to me and hear what I say. No one usually asks. And someone who absolutely loved it. Helen was so helpful and easy to talk to. She really helped. If it wasn't for her, I don't know where I'd be. I'm so thankful for her and will cherish my time with her for the rest of my life. That's quite profound, I think. It was quick and easy, always negotiated first and chased it when needed. So as I say, I wanted to put the voice of the children and young people first and foremost as a change rather than adding it as an extra at the end. But we've got great feedback as well from GPs. So GPs happy with the service, doing an amazing job, nothing but positive feedback. Parents talk about it as well, are very happy that their child has this support and a grown-up who they can relate to and talk to in school. And we have lots of fabulous feedback from schools as well. So this one in particular, they were able to reset the focus with those referring to have a more preventative focus and work with those where needs were emerging. So talking again about that prevention element before they were escalating, and those involved have been able to see the positive impact of this early intervention work, which supports young people to become more empowered. So social prescribing is about the prevention element of children and young people's mental and emotional well-being and also needs. It has that focus on prevention and intervention.
Hold on for a second.
I've just swapped mics in case that helps. Okay, so it's about coping strategies that can help further escalation, reducing the impact of multiple adverse childhood experiences, and it's about helping young people to access and engage with support services or support that's available in their community. So it's very much a person-centred approach, offering a safe, confidential space for children and young people, where they have an in-depth discussion to understand what they feel, what matters to me, their wider wellbeing and social issues. It involves motivational interviewing and behaviour change approaches, supported over about 3 months or 6 sessions, and it's generally offered in Shropshire for those aged 11 to 18.
Yeah, I'll just interrupt you a minute.
Yeah.
Can you change the way you're sharing your presentation to share the screen rather than, sorry, they can't see it on the live stream. You share the screen rather than the file.
Yeah.
Thank you.
Thank you.
It's not caught up yet, so bear with me. There we go. Hopefully that's better. Ah, yes. Thank you. So I just got up to the point where this is ideally aimed at those with low-level challenges. So providing support at this early stage, we're hoping to reduce the pressure on other services. And it's about encouraging children and young people to follow their action plan, engage in activities where appropriate, and follow-up support and monitoring of their progress. So children and young people themselves were involved in developing this personalised care planning action plan, where they kind of document what people like about me, what my interests are, what my help's going to be, what I'm going to focus on, and some kind of action planning in terms of numbers and information that they can access, telephone numbers or text support or online support. It's got a bit of an updated statistic since the report was issued. So we can see that in the year there's been 814 referrals. 108 of those have been made by GPs, but we can see that the overwhelming amount is by organisations other than GPs. So a lot of schools, EHAST, Early Help, CHAST, and we can see the main reason for referral is emotional wellbeing. So 583 of those referrals for emotional wellbeing, and some of them are for mental health and adverse childhood experiences and others. This is going to show a little bit more detail. I won't expect you to see it all and all the colours on these bar charts, but when we're talking about emotional wellbeing for children and young people, that can involve a number of things. So some of the examples are anger or anger issues, anxiety, school attendance, attitude, behaviour, bereavement, building confidence. These are all things that have come from the young person themselves when they're having that in-depth conversation with their advisor. And here we can show the difference. When I say we monitor before and after, we use a tool called MyCore, Measure Your Self-Concerns and Wellbeing. So we can see that, first of all, we're having an impact on the overall well-being of these children and young people. We can see the improvement there, and we can see 82% of those have had an improvement in their concern 1. So they work on 1 or 2 main concerns, as I just touched on earlier, and we are able to demonstrate that they're having an impact and making a difference in the life of that child or young person. A few examples here of our partnership work, and it's very much a collaborative effort. So with GPs and primary care networks, so some of the funding comes through primary care networks, and some of the funding comes through Shropshire Council. So we also partner with the early help whole system, including targeted early help, EHAS, the public health school nursing team, paramount, because our advisors are out there in schools, so making sure they're discussing their cases and making sure that they're sharing the issues. Step Up to Enable, With You Drugs and Alcohol Service, BU, brain bereavement counselling, school pastoral team, and also parents and carers where appropriate. Just wanted to show you the team actually, so I don't want to forget the actual team, the lovely faces of our Children and Young People's Advisor team. There's about 10 and a half whole-time equivalents, and there they are. Only one male among them, so I don't know if people are a bit isolated in amongst a team of young ladies. But here's my final slide, and I think this gets to the crux of what we want to talk about today, that contracts are being renewed with the primary care networks, and there is a recognition in the prevention nature of the Children and Young People's Social Prescribing Service. But we're really interested to see how this service could be potentially funded through a joint commissioning or collective model. And so that's my final slide. So thank you very much.
Thank you for that, Claire. So, I mean, combining the paper on the slides, really helpful summary of the offer and where the referral activity is coming from, and as you say, bringing at the front the voice of the child into that space. So, any initial, Claire, you're on a roll this morning, Claire.
Yeah, I never keep quiet. The chart, I mean, this is fantastic, and Claire knows how amazing I find the social prescribers and the work that they do, because it is truly person-centred, which is obviously what we're aiming at. In the charts, I just don't want us to lose, when we're increasing the wellbeing and the improvements, that we don't lose sight of those small amount of children and young people where it worsens, and making sure that we're understanding that and pointing them in to the right services. And I'm sure you are, but I just want to make sure that we note that, 'cause it's very easy to get caught up in that wider piece. I think it's really interesting to think about how we commission this going forward, when we've been talking about the preventative work, and actually align this to what is in that CYP JSNA, and how we try and match the two around population health, and then what we're delivering around the neighbourhood integration. And I think Nigel and I need to sort of take this away and think about how do we put that into the joint forward plan, and make sure that that's captured in the sort of the rolling 5 years going forward. So I hope that's more important to wanted to share.
Yeah, I'm on a teasing, Claire. So really important points in that actually. And Rachel, do you want to build on that? And no, Nigel's going to build on that. So
yeah, I mean, I think Claire's this is, for me, this is firstly a huge thanks to the team. Yeah. A very small team who was a huge amount with it's actually a very small investment compared to other services and the outcomes that have been delivered. So I thought we can't lose sight of that, and how we've built momentum, the links, the trust, the partner. It's an absolute partnership. And I think we pick up on children and people's mental health, but it's so cross-cutting, isn't it, in terms of some of those issues that risks that we're supporting and trying to support people to address, and support schools and other parts of the system in holding all this together. So absolutely, I think absolutely the bit around that's my point, I think, from the previous presentation. I'm worried that we're losing some of this, and we lose some of these. We've got to have a more sustainable model of funding for these services going forward. I think in terms of, yes, there's a link to primary care, but as you just showed, like, links to so many of our services. There's a benefit to so many parts of the system. So we absolutely need system approach to investing in this. We need to be serious about prevention, recognising that, yes, there is priorities across all this, but we continually deal with crisis. I get that we have to do that, but we have to run this alongside. And we've got something that's demonstrating an impact. my ask is that we absolutely do come together as a system and make sure we invest in this properly and not just piecemeal, and look at the scale we need to do this and the real benefits aligned to the integration, aligned to the one structure, aligned to our prevention framework that we committed to. So I guess I would absolutely welcome the opportunity for us to all come together very quickly in year and make some of those decisions and not just keep kicking it.
So would agree with that, Rachel, in terms of coming together, before I get misquoted, agree, coming together quickly and working through funding and what this looks like and next steps on that. I would value some help as well then from public health colleagues, because I think the bit that we struggle with in this system is being able to say, here are the priorities that we've agreed. Here's our decision-making framework then that sits against our priorities, and then how we make financial decisions aligned to our decision-making framework based on priorities that goes back to the JSNA. Because at present we do everybody wants everything. Yeah. We then talk about the scale of public sector financial challenges across all the public sector areas, and then say, but this is really important. Now, I'm not minimising, I don't want to lose this because this is really important work, but I think actually having a framework across the system that supported decision-making and investment decisions that were based on population health and health inequalities that would allow us to justify that and really bring a case to argue in terms of the difference this is going to make would help in some of those conversations and discussions. So I guess the bit I'd like to ask back is, help us with a decision-making framework that we can then use in that space, because that will make some of those conversations more, they'll still be difficult, but easier then to justify in terms of here's where we're trying to get to. Nigel then.
So 3 quick points if I may. I think the first one is it's a bit like trying to encourage instant reporting and then going, oh, the incidents have risen. This is positive that we've got an increase in referrals, because we're wanting to find out more, thanks to all the work that we've been discussing, and only with these referrals can we then start to put the wraparound services and as I say with that wonderful team. I think the second one is with that then the comms and the role of the service must have been publicised well to get people like the GPs and schools and others using it. That doesn't happen just by relying on osmosis. I think the final one links a little bit, Simon, to what you were just saying, which is if you've got very small numbers, which we might have had sort of a couple of years ago, as the numbers rise, I think that provides us the opportunity to analyse what the drivers for that is, which of course allows us to link back to the JSNA and others. And then that will allow us to understand, whether these services are indeed the optimum, or actually whether there's others there that could either help, or if we have to make difficult decisions about what the priority for funding is. And if this is the optimum service, then what else then is not necessarily able to, what may not necessarily need the same level of priority. So I think that analysis on some of that drivers might be really useful linking into that framework.
So Penny, then Naomi, and then I'll come back to you and we'll bring this to it.
Just very quickly today, I mean, mental health is a priority, and children and young people are also a priority of this board of SHIP. And so we know that this is a priority for us, and we've known it for a number of years. And I think it's nationally, as Tanya said, nationally, it's an issue as well. So I don't think there's any question it's a priority. And I think we also heard from Liam the scale of the issue is huge, like 28,000 children or something. It's absolutely massive. And I think would be helpful to have a framework, as you suggested, Simon, that takes into account the evidence of what works. So like you were saying, Nigel, what is the best thing to invest in when we have this issue? And when we look at what works, we can add that to the framework. So I think that would be helpful. I think there's no doubt that this is an issue we need to tackle. It's just what's the best thing to invest in.
And by no means was I minimising. By no means was I minimising that in terms of saying we need to decide it's a priority or not, because I agree with you. I'm saying against what happens in the conversations and investment conversations, the investment committee, where everybody says, I've got the strongest case for, the risk is then it's about who shouts the loudest rather than here's an evidence base that sits behind it to say, we're using public sector funds in this way, this has the biggest impact for our population or for children and young people. Just makes that conversation and discussion more evidence-based and less about who can write the best paper to present that. Naomi, and then Claire.
Thanks, Simon. I I think Penny's probably hit on the point I was going to make, but I wanted to round it back, I suppose, the presentation that Liam made around the access targets and really looking at, you know, what this services individually have to offer in relation to supporting children and young people within our system, within Shropshire, and what we can do collectively as a system. So if we look at the access targets that were shared, it's telling us that about 30% of young people who may need help around children, around their mental health, can be supported through a CAMHS core service. So then we have the other 70% of young people. How do we wrap support around them? And we have evidence of really positive outcomes for children and young people, not just through the preventative element of social prescribing, but through the research study we're part of with University College London now with MPFT, showing the evidence of impact of social prescribing on waiting well as well. So cumulatively, bringing together that impact and looking at those outcomes, we have to really think sensibly about how we wrap that support around children and young people.
Really helpful, Naomi. Thank you for that. So, Claire.
Thank you. Yeah, welcome the comments, and I think that's a good idea to have a framework for decision making. And I think that could be a real positive thing to bring, you know, real collaboration to this and bring all the partners in. So I think that'll be really good. Claire, in respect to your comment about the worsening need, just to say that if there are any worsening need, obviously we have referral and signposting links to all of those wider partners, school nursing, etc., safeguarding referrals, etc. So that is all attended to, I can assure you. And yeah, as Naomi mentioned, the wellbeing while waiting relates to Liam's presentation earlier. It's the research study to look at how social prescribing can support those children and young people who are actually on waiting lists for mental health support. So we'll look forward to the outcome of that. But in the meantime, I just think we can't lose sight of it, because this work is going on now. There is high demand for children and young people, as you've seen, at every level of the service. And our aim is to achieve prevention and to really help to support those children and young people and to stop some of those issues from escalating.
So, look, really great conversation again, and presentation and discussion. The board is asked to note and endorse the progress and improved outcomes for Shropshire's children and young people. Is to note the risks around the funding, and we've talked about that, and discuss the opportunities for the system to consider joint funding. So I think there's 2 bits agreed on that, which was partners to come together in year, stop kicking the can down the road, to quote Rachel, but also then think about the framework, which was broader than just the children and young people bit, but was around how do we reinforce the priorities. And I think the final bit that the board would like to do is be grateful, Claire, if you could pass on the board's thanks and recognition of the work to the team, actually, and make sure that they hear directly from us in terms of how this was brought to life today, the positive conversation that took place, and our thanks back to those as individuals delivering the service.
Thank you very much. They will appreciate that. It's nice to feel appreciated and have the positive feedback. So thank you.
Thanks very much. Okay, I'm going to move us on then, if that's okay. I don't want us to lose the importance of the next set of agenda items, but they are in the bit of the agenda which is approval of recommendations with discussion by exception. So I'm not expecting significant presentations on these, but committee members will have read the papers, but equally I don't want to lose any important points by going too quickly either, but just setting the tone in terms of the next chunk of items. So in terms of agenda item 8, ICB update, Claire and Nigel.
I wasn't proposing to talk through this. I think the figures are in the paper. As with all updates, the figures keep constantly changing. So I will circulate the most up-to-date because other colleagues have updated the figures. It doesn't significantly change the main body of the context, but I'm obviously happy to take any questions, but I think it's reasonably factual and self-explanatory. I think the only other bit that Nigel and I probably wanted to just talk about is the update of the joint forward planning process and making sure that we bring that to the next Health and Wellbeing Board for a review. There's not substantial change to it. It's a refresh, and also we're refreshing the integrated strategy that was approved by the Integrated Care Partnership. And really that's around making sure that the narrative is reflecting where we are today. So it's a used document, and the same with the joint forward plan. The most substantial change, I think, will be the system operating model that will be within that joint forward plan, but there'll be an opportunity at the next meeting to have a look at that. But that's probably all I need to say.
Yeah, thank you, Claire. And so two points from me. The first one, just a specific, if I may, just on the slides, especially looking at cancer performance to a certain extent with my SAF hat on, but the improvement and the reduction in the backlog of patients waiting over 62 days within our system has been the largest reduction nationally. So I think that's good news for patients who are waiting, obviously. I think the second bit, just following on from the point about the joint forward plan, there is planned to be a joint HOSC session on 16th of May, and Councillor Leeds for the joint HOSC have obviously posed a few questions on that. So it won't repeat the points that Claire has said. I think in that it's talking about, so some of the questions we're talking about, for example, the impact on local authorities, the impact on primary care. I suppose what I'd do is just reflect that the very nature of the joint forward plan is that this is absolutely developed jointly, and so there isn't impact. It's a joint focus, and much like we've just been talking about our priorities around children and young people, both from a health, of local authority, a wider set of partners, then it's really, really important. This is very, very much an integrated plan for that very reason. So really, really look forward to discussing and presenting at the joint HOSC and having that discussion. But I really would reinforce the fact that the joint forward plan has been really developed, a lot of input from a range of different partners, because it really needed that and it was right to do so. Thank you.
Thank you, Nigel. Any comments, questions by exception on the ICB update? No. So I'm going to move us on, and the board notes the contents of the update and the key points that are highlighted. I'm going to move us on to agenda item 9, Shropshire Food Poverty Alliance report. Helen, please accept my apologies for running 28 minutes late. Dreadful chairing on my part. But you're with us on Teams, which is fantastic. Assume colleagues have read the report, but anything that you want to bring to the board's attention in terms of highlights?
I don't think because everyone's read the report, but I think the main highlight that's relevant to the Health and Wellbeing Board is that 80% of the people we know using food banks in Shropshire have a long-term health condition or disability. Either that's a combination of mental health condition and physical condition. Usually, mental health is obviously something that's noted a lot by food bank coordinators, and that something we are focused on, and Emily will likely bring up in the point after me, is about income maximisation. We want to work as a preventative way. We don't want people ending up in food banks, and one of the ways to do that is to maximise incomes, and the ways in which we can work together to get that information out to people, I think, is the main thing from the report. So if anyone does have any questions or comments, or
I mean, Alan, I'm just thinking about your point, so thank you for that. And the report's self-explanatory and well written, so thank you for that as well. I guess the question for me is, if we think about the points that Rachel's made, that Claire's made in terms of prevention, the role of primary care networks, the role of neighbourhood teams, I guess that are we doing enough to link our signposting and support and other services around our food banks, given we know where we are and given we know how people are going to use them and need them and rely on them, linked to that physical and mental health need that you articulated, Helen? So I guess it's not for us to debate massively now, but the question is, are we doing enough to put the right support around colleagues who are delivering the support through the food banks to enable them to help signpost and redirect and support families and individuals get the right input? It's a genuine question in terms of are we doing enough and can we do more? Claire?
I've just written that down as well. So I think it would be really good to work with you, Helen, and your teams around the integrated neighbourhood team work and how we kind of do a reverse bit. So actually, how do we get the information that's coming through the food banks and link you into social prescribing, long-term condition management, what are the things that we need from that. So it's really person centred from the people that are using the food banks and what they rely on. Thinking about that kind of prevention signposting. So it might not be into the GP, it might be into other services. So I'll pick that up as an action if that's okay.
Thank you. I mean, the report that sort of supports this, that goes with it, just makes some really challenging reading, doesn't it, in terms of the impact and the changes, the significant changes in a small number of years on local people and people that we're here to serve. And so our response to this, and our response in terms of how we put the right support in and link with a different route of signposting, I think is a really important part of what we need to be doing.
Right.
Rachel?
I would only say, I mean, this is absolutely one shop. So yeah, I think your question is, are we doing enough? No. Can we do more? Yes. We are linked up, and that comes to the heart of it. But there's absolutely more we can do, and I think it links back to the previous point. So yeah, just to answer that and say we do make links, and I've got it on the screen as well. There's a lot of links here, but we need to make more, and I think absolutely great approach.
Okay. Thank you for that. Helen, any final comments you want to make?
No, that's great. I would really love to work together with sort of anyone and everyone to get that support out there for people. So that's great. Thank you.
I will reach out to you from my team and make that contact in terms of some of that neighbourhood team working that we're doing, and think about how we can support that as we've talked about. So thank you for that.
Great. Thank you.
Thank you. Okay, I'm going to move us on then on to shaping places, item 10 on the agenda. So Emily, I can see you've appeared on the screen. I'm going to come to you. I offer the same apology that I offered to Helen in terms of running late in terms of the agenda. But over to you, and again, work on the principle that committee members and board members have read the paper, but main bits that you would want to pull out and highlight for the board.
Thank you very much. And of course, there's some crossover between my paper and Helen's. I think the important thing to draw out is that although the cost of living crisis is easing, I think that prices have still remained really high, and people's finances are in quite a precarious situation. We know residents have built up debt over that time, and we know there's an increase in households with negative budgets, which means that they have less income coming in than they have going out. There's a real stigma around coming forwards for support, and there's a real need to help residents to navigate the system, because it is incredibly complicated how many different places you can go to for little bits of support. So what I kind of outlined in the paper is we really need to normalise conversations around residents' financial issues, and create any opportunities where there is an opportunity for a conversation around people's finances and could they maximise their income. We know that there are quite a number of benefits in Shropshire which are underclaimed, and there are also other opportunities around increasing your hours at work, or looking at things around budgeting. So we have been working to very much try to link up that information about signposting, and we have developed an Ask, Assist and Act toolkit, which really helps people to take residents through that conversation around how to get support. So we'd really, value your help in promoting that toolkit and to encourage those conversations to happen.
So thank you for that. I also enjoyed watching the video as well, that the link's in the paper. So it's worth it, colleagues haven't watched that, go and look at the video. So from the, if I take my chair hat off and put my chief exec of the Integrated Care Board on, I think Claire, Nigel, bringing some of this to our future huddle and us talking about this to the 200, 250 people that we get on a huddle. And actually these both previous last agendas actually, I think would be an organisational commitment we could make in terms of that, raising the profile, raising the awareness. And I would ask partners and colleagues around this table to think about how we do that within our own organisations to raise that profile, so that we can help support individuals navigate this as Emily's talked about. And some of that starts with us understanding and us having that awareness, doesn't it? Because then we can talk about that and support in the right place. So there's a commitment there, Emily, from NHS Shropshire Health and Wellbeing to do that. Any other questions and comments from colleagues on this? Can't see any other. No. It was your pen. Oh, sorry, I thought you were putting your hand up. It was your pen. Penny.
I would just add that I think Helen is coming to. We have got a One Shropshire integrated working around developing integrated neighbourhood teams and integrating that with One Shropshire workshop next week. Some of this work around, in particular, Act Assist Act, which is a way of working, is coming to that, and so it's something that we can build on going forward. And I imagine can I speak for you, Emily? I know Emily would love to go to a huddle and talk about it, because the more we talk about it, the more it becomes normal, the better that will be. So thanks for that suggestion.
Very welcome. Good. So we are asked to consider, discuss the content of the report, which I think we've done. Encourage members to take this information back into their organisations and consider if there are any actions which can be taken. I've proposed one from NHS Shropshire Health and Wellbeing, and I think the board endorses and supports the report and recognises the work that's taking place and the joining up. You were right, Emily, in terms of the overlap and the connection with the previous one, but also in terms of some of the neighbourhood teamwork that we talked on previously. So I think there's a lot connected in that space. So thank you for that.
Thank you very much.
Keep us going, if that's okay. So item 11 on the agenda is the chair's report. I've got a couple of pharmacy updates, of which there's been a change in hours at Rowland's Pharmacy. Not proposing to give that in detail, but we do need to publish it, and we'll publish it on the website. And NHS England, through their primary care support team, have notified the Health and Wellbeing Board of an application to consolidate MSN Farm Limited, which is currently in Claremont Hill in Shrewsbury, onto an existing site at the Tannery in Barker Street, Shrewsbury, run by Luntz Healthcare. If the Health and Wellbeing Board wishes to register an objection, that has to be completed by the 20th of April 2024. I've got nothing else from a chair's update to bring to the board this morning. So I'm going to keep us moving and say agenda item 14. Penny, anything to verbally update on SHIP?
Only to highlight that the two reports you just heard were also came to SHIP, so did at the last meeting, so did the long-term condition strategy, with a real recognition of that opportunities with the long-term condition strategy for place-based delivery, and how we can work together through the integration work in community and family hubs. And finally, and also the rural proofing health kit. So a few things that we mentioned today around morality and the issues we have there. So around how we can use that to develop our services, and then highlighting the CQC self-assessment that was done earlier this year. And of course, we do have an inspection coming in June.
Please, thank you for that. Any questions to Penny on the SHIP update? No. Agenda item 15, health protection update. Is this you, Rich?
Yes, I'm just going to link the last item to the first item, just to flag to everybody MMR and the need to keep our vaccination that was on our first item, and obviously the real push around that, particularly in targeted areas. Our rates need to be high, particularly the second dose, and the same with tests. We've had a rise in whooping cough as people know. So again, so you're seeing a lot of social media, and just to keep pushing that out through our networks and to anyone who's listening online to make sure that we push those messages out.
Thank you very much. So does anybody have any other business that they wish to raise that hasn't been covered, or points they wanted to highlight that we've not talked about on the agenda so far? Claire.
I just wanted to say thank you to the guys in Shropshire for organising the housing and health event that we had last week, because I know Cecilia was there. It was fantastic. There was really good engagement from partners across the private housing sector, and there is so much that's come out of that. And I think the conversations today really sort of lean towards those broader conversations are really, really important when we're thinking about the prevention and the improving outcomes for our populations. I just wanted to mention that from the Health and Wellbeing Board perspective.
Can I just add on to that, Chair, that we've got another one coming up next Monday, I think, Claire. So I hope you'll be there.
Certainly.
Where we will start refining some of the work that's been done, and hopefully we'll be able to come up with some really good ideas as a result of that.
And you were helping through that as well, okay?
Yeah, I was pleased to be invited. So it was a little bit out of our comfort zone, but as I say, that's where the magic happens. Good.
Good, thank you. So I think we've covered the agenda proper. Just a couple of reflections. I think having, I know this won't work on every health and wellbeing board agenda, but having a theme where the main discussion items flow feels like it just helped that conversation discussion to spend some time talking about that in detail. And so I think as we think about agenda setting and think about the areas that we cover, then I think us thinking about how we theme our health and wellbeing boards to bring a particular focus, I think adds value in that space. And I'm keen, it's always the clues in our title. This isn't about what's the NHS service look like for this. This is about the health and wellbeing of the population and residents of Shropshire. So the broadness of that and the ability to have that conversation, I think, is real value. And of course, then thank you to each and every one of you, both online and around the table, in terms of your input and contributions. I've spent all morning apologising for dreadful chairing of running over and running late, and now I'm going to take all the credit for brilliant chairing and finishing early and giving people a significant chunk of their morning back. And so thank you all. Louise is sitting there laughing to her little heart of content in terms of that. So thank you all for your time and contributions, and look forward to seeing you at the next Health and Wellbeing Board, if not before. Thank you all, and if you could let us know when we're offline, that would be appreciated.